So if anyone wants to be added in, just let them in, and please do shout out at me if you've got questions and whatnot, just purely because I can't see anything other than what you guys can see on your screen. Perfect. So your maternal history for this evening. This lady is a Gravida 1 paranaut. She has a medical history of wear and tear back problems. She is hypertension on labetalol pre-pregnancy. She suffers from migraines. She's a possible alpha thalassemia carrier and has a BMI of 39. She stopped her medication herself at 25 weeks as her blood pressure was normal, but from her obstetric reviews that she had early on, so she was seen by an obstetrician at 14 weeks who noted that she was quite non-compliant with her blood pressure medication anyway, although that seemed to have sort of settled in her pregnancy anyway. So she took herself off the tablets. At 27 weeks and 1 day, she was diagnosed with GDM. This was diet controlled the whole way through her pregnancy, so never needed metformin or insulin. At 36 plus 3, she had a growth scan for query large for dates, but also due to the diabetes, which showed her to have normal growth and Dopplers on the 65.8th centile. So she was offered an induction at 39 plus 2 for GDM. She had a baseline rate at this point of 140 beats per minute. I haven't included all of the antenatal CTGs purely based off of the fact that the labour CTGs are the ones that are where it gets a bit more interesting, and there was quite a few of them. So she had a ProPest put in at 16:30 on the 5th of the month. Shortly afterwards, so the ProPest kicked in quite well for her, and she started contracting regularly from a couple of hours later, actually. On the 6th of the month at 02:18, she was given some Entonox because she was complaining of pain at this point, and she was reported to be contracting sort of 2 to 3 in 10. And then at 04:55 in the morning, she became increasingly more distressed. Her cervix was found to be 9 centimeters dilated, and so she was transferred over to labour ward. I believe the station of the baby was -1 at this point, and the ProPest at this point was also removed. So this is 4:55 in the morning. Still remains on the 6th. She requested an epidural at 05:15. However, the anaesthetist at this point was busy with a case in theatre. She had a blood pressure of 125/79, a pulse of 74, respiration rate of 19, temperature of 36.7, and her BM was 6.6 at this time. So this was her baseline set of obs here. Unfortunately, she didn't get her epidural for, well, at least for the whole segment of this trace. At 5:35, she was vomiting plus. It doesn't report how much exactly what she did actually vomit in this case. But yeah, and then towards the end segment at 5:30 in the morning, she shrom bloodstained liquor. The doctors came and did a review of her CTG, and the plan was for an epidural, a cannula, Usinese, and an FBC. Anyone got any thoughts on this CTG trace?
Looks a bit flat.
Yeah, for sure. I mean, this is sort of 40 minutes here. Our baseline is still 140, which is what it was previously, so it's stable, which is reassuring. But yeah, our variability is definitely reduced in this sort of segment. She's in active labour, so we're not expecting any sort of accelerations. We're not needing those kind of accelerations. But after this sort of period of time, we would expect to see some form of cycling, or some kind of change or increase in variability here. As you can see as well, her TOCO was on and it was adjusted a couple of times, but it doesn't appear for her to be contracting very much at all. I think there's nothing really recorded on Cerner here for this entire duration of time. But for somebody that's 9 centimeters dilated, we would probably expect her to be contracting a little bit more frequently. So At 0600 in the morning, she is documented to be contracting 2 and 10, of which they were irregular and moderate on palpation. At 6:10 in the morning, she had some bloods taken, HB117, platelets 207, and a white cell count of 11.3, and her Usinase bloods were completely normal. At 6:20 in the morning, a third-year student midwife did her examination, confirmed her to be fully dilated with the presenting part -2. Just something I want to add in as a sort of key message here. We love it when our students take on these sorts of cases, specifically when they're confidence cases. But for things such as doing a sort of examination like this does really need to be checked by the midwife that's caring for this patient as well, which it wasn't in this case. I'm not sure whether or not this student midwife was very confident with her examinations, or whether she's done multiple, or whether she's done very little. But this is something that I think we need to stress, that it's great when we're doing observational things with our student midwives, when they're doing a skill whereby we can see the outcome of it. But for something like an examination to confirm full dilatation, I think this is something that really does need to be rechecked by the case midwife. Just as a sort of side note here. As you can see, our variability doesn't really show much improvement here. I think the baby did respond to the VE, but there is actually loss of contact when the VE was performed, rather than the kind of stimulation that we would expect necessarily from an examination. But yeah, what are we going to do?
For someone that's supposed to be fully dilated, I'd be expecting a few more, maybe decelerations or a bit more symptoms that this baby's sort of having head compression or something. And that's quite a high head at -2 at fully dilated. I'll be thinking what the bladder is doing. Is it an obstructive labour? Like, it doesn't look like a fully trace. I know you shouldn't say that, but
no, but yeah, absolutely. I mean, not that we would want to see those kinds of things on a CTG, but you definitely expect them. Just some kind of some kind of even barrow or even chemoreceptor decelerations, just to kind of show that the head is sort of moving down into the pelvis. There's no note of when she last passed urine before the CTG was performed, because she was obviously on the antenatal ward from the time her propus went in, when she was os closed, to the time that she was then 9 centimeters. And because she obviously wasn't receiving one-to-one care, I think fluid balance is something that we neglect quite a lot in maternity, and I think it's something that we definitely need to improve on. But if we're going to assess the bladder and we're going to see whether or not this labour could possibly be obstructed, then we need to keep a very close eye on that. She's obviously been in the unit on the labour ward now for about 1 hour and 20 minutes. There's no real report of that on Cerner as to whether or not she has passed urine, or when the last time was, or if she was even asked. But yeah, you definitely expect someone that's fully dilated with a presenting part of -2 to have something else that's going on that could be then affecting the way that this baby's coming down through the birth canal. So what are we thinking in terms of this reduced variability? What do we think is going to improve it? Or what do we think we can do to try and, make this CTG look better?
Hi, Cara.
Sorry.
Oh, sorry. Cara, it's Katie. I don't say this is going to make it better, but can I ask if did they put up fluids at any point?
No.
Good news.
I'm glad that you've mentioned that though, Katie, because this is a running commentary that we have very much at Croydon, where we love a bag of fluids. We love to think that these fluids are going to fix our CTG. In this case, however, if she is dehydrated and she is like fluid retentive and whatnot, maybe encouraging her to pass urine, putting up a bag of fluids is going to help her feel better. However, her bloods are normal, her observations are normal. There's no report of her being dry in any kind of situation, so fluids wouldn't necessarily be a thing that we would recommend, unless obviously she is going to have the epidural that she has requested. But yeah, no fluids at this point.
Do some conservative measures, change position potentially.
Yeah, absolutely. Absolutely. Also, she's fully dilated. Let's try a few biomechanics. You know, if you've got a high head and she's full dilatation, you know, moving into sort of left lateral position, on getting on the peanut ball, something along those lines is probably going to help us, specifically with the descent of this baby as well. That's not done in this segment. However, if we move to the next one, at 06:50, she gets up and she's more sort of walking around. She goes to pass urine in the toilet, as you can see the small gap there. Although it says loss of contact, I'm not really sure how that correlates when when it's reported that she's gone to the toilet. But it says that she has passed minimal urine at this point. It doesn't say how much, but when I think minimal, I think sort of less than 50 mils. That's just the way my brain kind of thinks. So when she gets back into bed, they do an in and out catheter and 200 mils of urine is drained from the in and out. Now, our bladder care guideline, I'm not sure, I know that we've got a few people on this call from other trusts. Our bladder care guideline is very much if your residual volume that you get from an in and out catheter is more than it was that you passed, then a catheter is actually recommended. This is more for your sort of postnatal care, but it works the sort of same in the antenatal or the intrapartum period as well, whereby that's quite a significant difference. So an indwelling catheter is definitely something that we would recommend in this case. However, unfortunately, that wasn't done. We've now spent maybe 2 hours on the labour ward here, and we still haven't seen any pickup with any kind of increased variability. It looks like she's possibly contracting a little bit more frequently, so maybe bordering on the sort of 3 in 10 mark, but still not really any report of any palpation of these contractions or anything like that, and very limited sort of recommendations as to the movement of the woman or anything that we're doing that could help improve this CTG. The thing that also concerns me in this case is when I do an examination on a baby, I'd like to see a lot of response to it. And as you can see from the previous slide, we're not really getting any of that from when this woman was examined. Possibly around the 06:30, that could have been sort of delayed response from this baby. However, when we're sort of seeing that on a VE, we'd hope that there would be some sort of stimulation that would perk this baby up a little bit. And even though it may have done as a delayed response, it's actually gone back straight to normal. Still has a good stable baseline of 140, but we've still got reduced variability here. Now, at this point, obviously, I'm thinking human factors wise, it's now 7:20 in the morning. The midwife that's been caring for this woman is probably getting to a very, very tired point of time where the clock is ticking and they're waiting for 8 o'clock to hit, which is when our handover tends to start. But at the same time, what are we doing about the fact that this baby's now spent 2 hours with significantly reduced variability and sort of no presence of anything reassuring? And she's fully dilated.
Sarah, sorry to disturb you because I just finished my antenatal and it was late. So she's prime and she's fully, isn't she?
She's primate. Yeah, I'll just take you back, Mr. Naguib. So she's normal growth baby, diagnosed GDM. She had a ProPES put in at 39+2 at 4:30. Baselines remained 140 throughout. She was very, very quick progress from the start of induction. So she was 9 centimeters at 4:55, and then she was examined and found to be fully dilated at 6:20, and this was done by a student midwife. And as far as I'm aware, this wasn't confirmed with the case midwife caring for this woman. And we've also now had reduced variability for a period of about 2 hours.
Right. Thank you very much. Thank you.
No worries. So at this point, if this was me as the case midwife, I would be requesting an obstetric review. They may be busy. As far as I'm aware, the acuity on the unit wasn't too bad on this particular evening. And I think this lady was one of 2 that were in labour, in active labour at the time. So obviously eyes are going to be on both. She was in a room as well that had central monitoring, so this would have been coming up on the screen. So at 7:35, an hour and 15 minutes post fully dilated, she commences active pushing. You can see some loss of contact, my favourite three little letters that everybody puts on the CTG. When I speak about loss of contact and when I see it on majority of cases that we do, what I want to know is, why is there loss of contact? What exactly are we doing about that loss of contact to try and improve the contact that we're having? At 7:47, the contractions are reported to be infrequent. Obviously, we love the use of technology with the tocos, but at the same time, we need to make sure that we're palpating these contractions and ensuring that they are actually happening. At 7:47, she's reportedly feeling very weak, and her pushing is very much ineffective, according to the case midwife. At 7:50, the contractions are palpated and they're found to be sort of 1 to 2 in 10. So the registrar comes in, does a review, finds her to be fully dilated, and the plan is made for an epidural and then second stage Synto.
Is there any documentation of her pulse or the stations of the baby's head or anything?
So the fully dilated was reported to be at -2 from the registrar. And in terms of maternal pulse, the first set of observations that you saw back at, I think it was 5:40 or something, that she came over to labour ward, were the only set of observations done within this current time period.
So no hourly pulse.
I
No.
just want to know why at fully dilated she's not contracting as frequently, and why the head's so high.
Yeah.
And the fact that it looks a bit more reactive in this one. I don't know if it's just loss of contact, but I think potentially why is everything stopped now? What's happening? What's the whole picture? Are her observations changed at all? I know she's GDM, so are BM's normal?
So the
I
only
wouldn't
BM
be-
that was taken was the one on that initial set of observations that were taken for her at, when was it, around 5:20. So that was when the last observations were taken.
And
It's now
has she
been
had
2
any
hours.
pethidine at all at any point?
No pethidine. This is now 2.5 hours post those observations and that BM being taken. I totally agree. I think the variability almost like it looks like it's improved during her active pushing. And what I do also think is a somewhat reassuring is the fact that this baby appears to have been stimulated by the obstetric registrars for you, when they confirmed that this baby was fully dilated. But what I'm now thinking is, okay, we've now had an hour and a half since she's been fully dilated. The plan's for an epidural, the plan is for Synto. The epidural is going to take 20 minutes to be placed and then 20 minutes to become effective. Synto, we would normally give, we'd titrate it up every 15 minutes in the second stage. But how long are we going to leave this woman being fully dilated? And my other question in this case was, we started active pushing at 7:35, and then we've only given this woman, 15, 20 minutes of pushing before the plan's now completely changed. Is this something that we could have maybe done slightly earlier when we were concerned about the CTG, and tried to get her an epidural and maybe started Synto when we knew the contractions were only 1 to 2 in 10 over an hour ago?
Cara, I just wonder what your opinion was, just in the fact that there's been reduced variability for, you're saying, kind of nearly 2 hours, and it's good that there has been some reactivity on the examination, but just maybe starting Synto on a trace with low variability for quite a long period of time,
Yeah.
that would make me feel a little bit worried.
Yeah, me too, Katie. And I think that was, I when I first initially reviewed this CTG, back when it did happen, I sort of was looking through it and I thought, okay, interesting, yeah. And then it's only when I've kind of put the overall clinical picture together, I've started to think, okay, there's a few things here that are a bit of a concern. I mean, if you've got a baby that's spent over 2 hours with reduced variability, that's showing you signs of stress. So if we're questioning whether or not we now want to add an additional stressor to this fetus, we want to add a synthetic hormone that we know can have quite a significant impact on a baby and cause more stress. We're then adding stress and making more stressed, which would be very concerning. However, what are our alternatives to doing a CTG, and what are our alternatives to a lady that's fully dilated, that's apparent? Oh, I forgot to add in, it's a direct OA position as well. Sorry, should have mentioned that. You've got a direct OA position as well here. Would we just immediately decide, okay, she's been pushing for 20 minutes, we're going to take her for a cesarean section, or are we going to try and play this out and think, okay, is there a chance that this baby can progress with, or this woman can progress and those contractions can pick up and this baby isn't going to get more stressed if we add Synto as an additional factor to it?
To be honest
Cara,
with you, Cara. Yeah.
Sorry, Mr. Naguib. I was just about to ask her. I joined. Sorry, I joined late as well. But Cara, I joined late as Mr. Naguib. I heard you when you were giving an update to Mr. Naguib. But has the membrane been ruptured as well, or did she rupture spontaneously?
Yeah, she ruptured spontaneously. So she shone bloodstained liquor about an hour ago.
Okay, and when they said she was having 1 in 2 contraction, at that point, it was because you said about an hour prior to this time we're starting Synto and epidural and then Synto. Was the registrar informed so that we know what actually, and did they document maybe the discussion with the woman and her opinion or preference as to what she prefers?
No, so the registrar was present throughout the CTG was obviously on the central monitoring. The registrar was informed when she was fully dilated, and the registrar did a very brief review back at 05:30. So back here, the registrar reviewed, and the plan was for her to have an epidural, a cannula, and have some bloods taken. This is purely by assumption because I was obviously not there in this situation, but I know that we with our women that are 9 centimeters dilated, if there's going to be a delay with the anaesthetist, it's very much a case by case situation whereby, okay, is she actually going to have enough time for an epidural before the baby's going to be born? And is that epidural going to have the right amount of time to become effective before we then start pushing or before the baby's even born, for example? So there's no report by the midwife or from what the midwife has documented from the woman, then further requesting an epidural. However, that was part of the obstetric plan made at 5:30 in the morning. So the obstetric reg was made aware of the fact that she was fully dilated, and the plan was very much to go ahead with active pushing 1 hour post fully dilated to give her that time for passive descent. Now, the woman, as well as being fully dilated without an epidural, normally, more so for maybe a multip than a primate, but normally within that hour of passive descent, you'd see some kind of, or you'd get some kind of report of the fact that this woman may be feeling as though they felt pressure or as if they felt like they needed to push, but there's no report of that in the documentation from Cerner at all. So the registrar came in and did an examination, said that she was fully dilated, and then obviously the plan was made for her to have her epidural and then for things to sort of go from there, essentially.
I don't know, Cara, if it was me. I don't know. Again, I don't know the case, so I'm acting prospectively here. I wouldn't personally have put it into at -2 at full dilatation that was initially, according to the history you mentioned, somebody who progressed so quickly. So I don't think she's lacking momentum. I would think of secondary arrests of the head, and I would be really cautious on starting Synto at this situation.
Yeah.
Number 3, I would also want to know if the obstruction kind of is due to the bladder is full, for example. So rather than like trying to start a hormonal treatment of the situation, I would first put a catheter, for example, if she hasn't had a catheter. I heard you said there is no catheter, isn't it?
Yeah. So she went to pass urine, Mr. Naguib, and she had very, very limited urine pass, so that's not reported the amount. But
No,
when
so
my brain
yeah.
goes to minimal, it says sort of around 50 mils or less.
So this is another indicator of saying to myself, this is a secondary arrest with obstruction. So I would be really inclined to put a catheter. My plan would be spinal catheter, examining theater for possible trial, otherwise C-section. I wouldn't be giving syntocinone at this stage.
Thank you, Mr. Naguib. So I'll go to the next segment that you can see here. She has her epidural test dose given at 08:35 in the morning. As you can see, our variability still remains very much reduced. And this is now when we start to get some observations. So her blood pressure is 148/94 at the end of this CTG, and her pulse is now 122.
Cara, there is a sound in the background.
Yeah, I think somebody's not on mute. Oh. Fantastic. So we've now got a woman who has been fully dilated for 2.5 hours. She's got her epidural sighted. It looks like her contractions may have picked up a bit here, so we're bordering more on sort of the 2 in 10. She has a heart rate of 122 and a blood pressure of 148/94. This is post epidural as well. Normally, when we have women that have an epidural, we'd see a decrease in her blood pressure. The one that was done previously when she was admitted to the labour ward was very much normal, sort of 120/80, I think it was. So we've had a significant increase in her blood pressure as well. Whether or not this was due to pain, or whether this was something else that was going on with her, specifically with her history of hypertension pre-pregnancy, this would be something that made me think, okay, I think we need to maybe treat this. And she's also got a heart rate of 122. So something more sinister is possibly going on here.
Is there any bleeding? So blood stain ichor, but is there any bleeding?
No active bleeding, but there is still remaining blood-stained liquor.
So if I add on top of what you mentioned, Cara, a pulse of 122, so tachycardia, high head, minimal urine, fully and still not coming down, I think I am more certain of an obstructed labor.
Yeah.
So, I mean, I wouldn't, again, put the Synto up on this stage.
Yeah. Absolutely. Absolutely. Saoirse, sorry, were you going to say something as well?
Yeah, just the abdomen, are they palpating? Has it got any good resting tone in between? Just because I've got this horrible feeling of a rupture, just because obviously the head's so high, minimal urine output, blood stain ichor. I'll probably jump into conclusions, but the CTG is not normal, which we don't seem to have classified. And I just feel like there's something. Is there good resting tone there? Has it been documented?
No, unfortunately not. So at 9 o'clock in the morning, this baby is examined. Sorry, there's quite a lot of information on this slide. At 9 o'clock in the morning, she's examined to place an FSE. As you can see, there's significant artifact that goes on from this. So it's actually taken off at 9:10. The doctors come and do a ward round at 9 o'clock in the morning. The cervix is examined. She's found to be 10 centimeters dilated. The presenting part is now -1, but still in a direct OA position. there was quite a big discrepancy between the midwife in charge, the registrar, and the consultant's concerns over this CTG. The midwife in charge and the consultant were very keen that this woman needed to be delivered and were concerned for the overall care. And the obstetric registrar was happy to continue. The plan was made to take some PET bloods. As you can see, her blood pressure is still at 9 is 165/102, and her pulse is also 130 at this point as well. At 9:16 in the morning, Synto is started at 6 mils an hour, and this is when we get documentation of 2 in 10 contractions where they're moderate on palpation. She's given labetalol to treat her blood pressure, 300 milligrams at 9:25 in the morning. She's then done another in and out catheter as she's about to start pushing, and 5 mils is drained. From that 5 mils that was taken, she had a plus of ketones and a plus of protein. And MSU obviously wasn't sent because 5 mils wasn't enough to send off in the urine pot, but there was no report of this then being attempted later on. Again, with the in and out catheter, obviously we know that that's going to drain it, but having an indwelling, despite the fact that you're going to start pushing, if you've got a woman on an epidural, an indwelling catheter comes as part of the package. When we've got women with epidurals, normally we don't remove the catheters and do in and outs throughout their entire second stage. We keep the catheter in and we deflate the catheter balloon when we're starting to push, just in case that was going to get in the way. But again, that wasn't the case here. And then only 24 minutes after the Synto has started is active pushing then again recommenced. So
Sarah,
there's been no increase in her contractions from starting the Synto. We haven't given the Synto adequate time to work anyway, and we still have a CTG whereby we've got reduced variability that's now been going on for about 4 hours.
Cara, just to clarify, please, just a question.
Mm-hmm.
You said there was a discrepancy between the different opinions during the ward rounds in the morning.
Yeah.
Was it not consultant-led ward round?
It was a consultant-led ward round.
So I would have thought so I would have thought it would have been a consultant decision. Why would there be a discrepancy? I'm just curious.
The registrar made the decision to start Synto, and I think there was an agreement that they would trial it. However, the midwife in charge and the consultant did advise against it at this point in time.
Yeah, I agree with Emmanuel. I don't understand if the consultant was not happy, why the consultant did not take the action needed to finish the situation. I don't understand that.
No.
Right. What happened next?
What happened next was blood pressure came back sort of normal-ish, and the pulse did reduce down to 101. At 9:53, a litre of Hartmann's was started. Now, routinely, we would start a bag of Hartmann's at the point of the epidural being sited. However, this was obviously significantly delayed. And the Synto was increased to 12 mils an hour at 9:57. She's still active pushing with her contractions at this point. At 10 o'clock in the morning, the midwife reported this woman to be pushing well and reported contractions 2 in 10. However, still no documentation of resting tone palpated. BM was 6.9 at 10:18. At 10:23, the consultant comes, does a review, and agrees for this Synto to be increased to 24 mils an hour. Now, normally when we do a second stage, what I found out today, which I did not know beforehand, was that we don't actually have any kind of second stage Synto within our guidelines. What I also couldn't find very well was there's no sort of recommendation for it on NICE guidelines, nor is there anything on the RCOG, which just begs the question how much research is actually done into second stage Synto to start off with. But the fact that it was difficult to find anything that we could use as like a reference point was quite difficult. From my understanding of working at Croydon, we've always in the second stage titrated the Synto up every 15 minutes until it gets to a point where she's contracting regularly. Whereas there was clearly concerns here because the Synto was very much delayed to a point where it was then increased a lot in a longer period of time. But it was agreed upon for the Synto to be increased again to 24 mils an hour. However, we still, for the last now 5 hours, have not had very good variability. We've also now been fully dilated by the end of this CTG for a period of 4 hours.
This is more like a chronic hypoxia going on. That length of time reduced variability.
Yeah, Indra, I don't disagree with you here. I think the CTGs previously were normal. Chronic hypoxia is something that's more commonly associated with an antenatal event, so something that you'd pick up with when that without the base of sort of with contractions or anything like that. Or we could be at a point where we've actually got a gradually evolving hypoxia, which is sort of decompensated. We've got reduced variability, but we haven't had a rise in baseline until the sort of last sort of 10 minutes here of the CTG when it does go up to 150.
And what was the CTG before this lady came to labor ward? Were they all like normal, good variability?
Yeah, normal, good variability and very much a stable baseline of 140. So there was no antenatal concerns with her CTGs at all. So it was only when she came to labour ward that obviously we're looking at something that's a lot, well, it's not normal. But then she has progressed incredibly quickly as well. So yeah, it's now been 4 hours fully dilated. I'll go to the next segment. Her PET bloods came back. Her ALT was 27 and her ALP was 286. The registrar comes in, does an additional examination, and the decision is made for a trial of instrumental in the operating theatre. At 10:43, the Synto was stopped. At 10:59, the pre-meds were given, and at 11 o'clock in the morning, she was transferred to theatre. Our baseline has now gone up and is bordering on around 170. We've still got reduced variability here. Presence of possible decelerations, they look more sort of chemoreceptor. If you look at the one that's at around 10:34, that's possibly one there that's kind of late from that contraction, but not really any sort of preceding decelerations here, which kind of makes me think, okay, is this more maybe infection related? Normally when you see this kind of hypoxia where we've got reduced variability and a rise in baseline, you commonly associate it with previous decels. But the fact that this has sort of gone up, she's also had multiple VEs at this point. I think we're on VE number 4 or 5 within quite a short space of time as well. It makes me think, okay, what's going on the inside? Are we all in agreement that we take this woman to theatre?
Yes, please. Yes, thank you.
Yeah.
You should have been there a long time.
We probably should have been there about three hours ago, yeah. So this is your theatre CTG. Baseline has risen up to 160, and baseline was obviously previously 140. At 11:27, the decision was made for a caesarean section as per the examination done by the consultant. Still -1, I believe. At 11:31, knife to uterus, and at 11:34 we had delivery, and the head was reported as being plus impacted, which I think we would all expect, considering she's been fully dilated for now 5 hours.
Just to ask her, do you use a fetal pillow at Croydon at all?
We do, yeah, we do. We do. It's very much sort of obstetrician dependent, but yeah, we do use a fetal pillow.
So was it used in this case, or was it the head was quite high?
I'm not sure if it was used actually. There's nothing in the documentation, so I'd assume that it was a no. Would anybody like to guess the outcome for this baby?
HIE.
Yeah. Anyone else?
Possibly quite a high lactate on the cord gas.
Well, I'll let you all know. This baby was born at 2935 grams on the 13th centile, which was estimated to be on the 68th. APGARs of 6, 8, and 10. The venous gas was taken, and this was also done by a student midwife without supervision. pH of 7.29, base excess of -2.5, and a lactate of 3.7. This baby had very minimal respiratory effort, was pale and floppy at birth. However, suction was used and the baby cried. The paediatricians left theatre 15 minutes later. 10 minutes after that, this baby looked pale and floppy again and did not respond to vitamin K, so the paediatricians were called back. They came back. This baby was reviewed and was normal at this point. Within 45 minutes, this baby started grunting, had mild recession, was given a first feed to see if that would settle it. Observations at 1 o'clock were completely normal. The peds came at 13:10 to do a review, did a blood gas, and the capillary gas pH was 6.8 with a base excess of -12 and a lactate of 11.4. This baby was then admitted to neonatal unit on admission. SATs were 98% in air. However, dysmorphic features were noted, so there was a query whether or not this baby was T21. However, that was later discovered as not being the case. The repeat blood gas that was done in SCABU was 6.98 with a base excess of -13.1 and a lactate of 11.9. This baby met criteria A for cooling, was transferred to a tertiary unit with HIE at 22:30, and this baby is now out of the unit with a grade 2 confirmation of HIE.
Dear.
Do you know where the HIE is on MRI, Cara?
I'm afraid I don't.
You are aware of the kind of study that different kind of grades of hypoxia or infection affect different parts of the brain. So therefore, reviewing cases would always make sense to kind of look at that, because I'm not convinced that this is an hypoxic trace.
I want to ask as well, Cara,
Mm-hmm.
the dysmorphic features have confirmed that it's a trisomy.
No.
So
I'm wondering if this baby might have been in a malposition, but do not know if it's not clear from what Cara said. But high head, small baby, why? So unless she has a kind of really kind of weird passage, i.e. pelvis, then it's normally that they're so dysmorphic because they quite literally have been for hours in a really strange position. No? I mean, really weird and wonderful OP or brow babies look as if they were in a boxing match or like a dolphin, no? So therefore you can have babies looking entirely dysmorphic because of that, and that would explain why in a so-called OA position, no descent in a small baby occurred. So that was the kind of case. But that is just as an assumption. I do not know, but that is what I would read into this.
and also the gas is being 7.29, and then 6.8 and 6.9 on the outside means possibly, as we discussed before, possibly a cardiac condition of the baby. Has it been confirmed anything on cardiac baby or any abnormality of the baby?
No, just the HIE diagnosis.
So now it's confirmed HIE.
Yeah, grade 2.
Did the baby?
Sorry, Dagmar, carry on.
No, I didn't mean to interrupt. I'm sorry, sir.
No, Dagmar, please. Yeah.
As I said, we haven't seen any significant hypoxia, no? So hypoxia you can have either because of intrapartum or postpartum events. If the baby had essentially never been oxygenated enough, you can have an HIE because the baby can't establish breathing. So therefore my suggestion then would be rather kind of primary pulmonary hypertension, or there was never any meconium kind of mentioned, but so that the lungs were essentially not okay, it wasn't found. Okay, and then the other kind of reason why you can have a significant brain injury, which we still label as HIE, is because of an infection. So what were these? And the lactate is high, no? So it gets high really fast. So was it purely because of non-oxygenation or non-being able to breathe it off, or was there ever a significantly raised CRP with this? Do you know?
I don't know the CRP, I'm afraid.
And then my last question is, you can have significant HIE if you have other contributing factors. So for example, if mums are hyponatremic, yes, or if they're having renal failure, so she didn't pee at all. Because maternal U&Es are newborn U&Es, they're identical when they're born. If a baby is markedly hyponatremic or has any U&E kind of problems, then the brain is due to either resulting edema or kind of changes on the cell walls, markedly more susceptible to kind of developing HIE. Do we have anything like that?
Say that again, sorry, Dagmar.
Were there any other kind of U&Es or kind of issues with the mother?
No, so all the bloods that were performed, I've included in the slides. So the only thing that was raised was her ALP, but the U&Es that were taken previously, like at the very beginning of labour, when she had poor urine output, were completely normal.
Mysterious. Did we send the placenta for histopathology?
Yeah, but unfortunately, it's not back yet.
Back yet. Would
Yeah.
like to know what the outcome there is, because this is not hypoxia.
Did we ever get a PCR?
No.
Did her blood pressure stabilise postnatally, or does she need treatment at all? It did. Okay.
Yeah,
fine.
that one dose of labetalol that she had sorted it out, and then there was no. I don't think they repeated any PET bloods, because obviously once that labetalol was given, her blood pressure normalised, and then it didn't go up again after that.
Be interesting to see what the placenta says. That GDM and query hypertension as well.
Yeah.
It seems to be the placenta insufficiency, maybe.
Yeah.
So Cara, now it is declared as HSIB, isn't it?
Yeah.
Okay, because the last thing I heard was the dysmorphic feature, and they were about to do chromosomal analysis.
So they did do it, and it was not chromosomal abnormality.
And there is no cardiac. We confirmed no cardiac, no metabolic, no nothing.
Yep.
Okay. That's strange. Okay.
Thank you for sharing, Cara. That's a really good case.
Yeah,
Thank you
so
everyone
much,
for
Cara.
your contributions. Thanks, everybody.
Thank you, Cara, so much. Thank you.
Thank you, Cara. Thank you. Bye.
Thank you. It's brilliant.
No worries.